So, all right, we're recording now. So feel free to stop me at any time if you have any questions throughout the presentation. I would like to make it more of an interactive thing, just so I'm not talking the whole time, because trust me, I am a talker and I'll just keep going. So feel free to unmute and ask a question, or to type something in the chat as well. All right. All right, so I will go ahead and share my screen with you all, and we'll talk about medications, and we'll talk about dosage forms of medications as well. So who can name some dosage forms for me? So I'll start off with the easiest one, and I'll say a tablet is a dosage form of a medication. What are some other ones that we could think of?
Liquid.
Liquid, excellent. So liquids can come as syrups, which are mostly sugar-based, or elixirs, which are mostly alcohol-based. You have suspensions and you have solutions as well. Good. What else? I will tell you that when I'm sharing my screen, my chat function usually doesn't pop up for whatever reason. So you might have to unmute for this part. Any other dosage forms that we could think of?
Like an ointment maybe, or like a salve?
Absolutely. An ointment or a cream. Yep. Anything that a topical thing that goes on your skin. Sure. Anything else? All right. Well, we'll find out a lot more about some dosage forms. I'm not going to read you the objectives for now. But so this is a definition of a drug, right? So it's a medicine or other substance which has a physiological effect when ingested or otherwise introduced into the body, right? So this could include prescription medications, this could include over-the-counter medications, this could include illicit street drugs as well. So it has a physiological effect. So it affects your body's physiology whenever it's ingested. So that is the technical definition of a drug. And so here are some routes of administration. So one thing we forgot to mention, nasal, right? So nasal sprays. Every year around May, June, my allergies start acting up and I have to use a nasal spray. We have inhaled as well. So inhalers, if anyone's maybe had asthma, maybe as a child, or maybe currently still does have asthma, inhaling medications, that goes down the trachea straight into the lungs. So it's a direct route straight into the lungs. You have the oral route, which would go down your esophagus, into your stomach, into your intestines, and then absorbed into the bloodstream that way. And we'll go more into detail into each one of these. Intravenous, and intravenous is unique because it's the only route of administration that has 100% bioavailability, and we'll talk about what bioavailability means a little bit later. The rectal route as well, so suppositories are a way to administer medications as well. Subcutaneous or intramuscular injections, a lot of our vaccinations are subcutaneous or intramuscular injections. So subcutaneous meaning just under cutaneous, the cutaneous skin layer. Intramuscular injection, so that goes a little deeper, that goes into the muscle. And then we have transdermal and we have topical. So the difference here between transdermal and topical, and we'll talk a little bit more about them a little bit later, they both go on top of your skin, right? So both dosage forms go on top of your skin. Topical just works at the site where you're applying it, right? So maybe I have pain in my back and I apply a topical cream or ointment or a patch, and it's just going to work at that site. Whereas transdermal, you apply it to your skin. However, it actually gets absorbed through the skin, it goes deeper than the subcutaneous layer, and it gets absorbed into the bloodstream, and it goes all throughout the body. All right, so anything that goes throughout the body would be, and it's applied to the skin, would be transdermal. All right, and so we'll talk a little bit more about each dosage form. So intranasal, so a solution of medicine in water or in alcohol and sprayed into the nostril. The advantages here is it works locally and not systemically. All right, so what does that mean? So anything that is absorbed systemically means it goes all throughout your entire system, right? So anything that goes into the bloodstream and throughout your entire system would be absorbed systemically. So what do you think an advantage would be that a medication would work locally and not systemically? Why is that an advantage?
I would think I know the most common that I know about nasal sprays is like, yeah, you said like allergies and stuff. And
Mhm.
so when that medicine can just target like your nasal passages instead of affecting your entire body, then like the rest of your body doesn't have to process that medicine. It's not a negative effect. Like even taking like I don't like taking like ibuprofen because I feel like it's bad for my liver. So that will just affect the specific place you want it to affect.
Excellent. That's exactly it, right? So side effects, right? So that's how we get side effects of medications. When a medication goes to a site where it's not really intended to go to, it can cause side effects at that site. So you mentioned good with the ibuprofen with the liver. Really, it's acetaminophen or Tylenol and the liver is the one that you have to kind of worry about there. So good. So it could cause some side effects if it goes to places where it shouldn't go to. So we would rather medications work locally rather than systemically. We just don't have the science to do that for every medication, unfortunately. It's interesting. I actually had a patient one time who got 2 prescriptions for 2 different opioids from 2 different prescribers, opioids being pain medications, right? So one was for hydrocodone, one was for oxycodone. And I mentioned to the patient, I'm like, I can't fill both of these because they're the same class of medications. They work the same exact way. And she comes back with, well, one is for my knee and one is for my back. And I said, well, the medication isn't smart enough to target where it's supposed to go, right? They're oral tablets that you take by mouth. They're not quite smart enough to target your knee or your back, unfortunately. So they work the same exact way. And so I can't give you both of the medications because there's a good chance that you're going to have worse side effects and overdose on them. So we're not going to fill both of them. And so then I would call the prescriber, one of the prescribers, and say, okay, so here's what's going on. Which one should I fill, or which one would you rather me fill? So a lot of times, unfortunately, we just don't have the science to make medications work just where we want them to just yet. But that is an advantage of intranasal nasal sprays. They work just there. And so they work much faster once they're working locally just at that site. Some disadvantages, some patients might not tolerate them. I do have patients who are like, nope, don't want to take a nasal spray, which is totally fine. And then can cause some local irritation. So maybe a nosebleed or dry nostrils or something like that. Moving on to aerosols or dry powder inhalers. So usually they have a propellant with them. So it kind of helps push the medication out and down into your lungs. It could be sprayed into the mouth, or you could use a spacer. So a spacer is kind of like a chamber, right? So you'd put the inhaler on one end of the spacer, you would push down and have the medication go into that breathing tube, and then your mouth is around the other end of the spacer, and then you would breathe the medication in. Well, so that could be kind of difficult, right? So one of the disadvantages here is it requires significant patient education and coordination. So anyone who's maybe used an inhaler before, it's hard to coordinate sometimes, pushing down and breathing in at the same time. What we're seeing now, which is great, is inhalers coming in more of a Respimat dosage form. So Respimat being, it's more of a mist instead. So you would push down and it causes more of a mist that you could just kind of breathe in at your own pace. Good things here, they act directly in the lungs. So you breathe it in, it goes right down into the lungs, and they act pretty quickly. Nebulizer is kind of similar. The difference here between a nebulizer and an inhaler, though, a nebulizer, they're mostly solution droplets mixed into the air or oxygen. So you put the solution, the medication, into the nebulizer itself, and it kind of creates it into more of a mist as well. And so you just kind of sit there and you kind of breathe it in. The problem is, first off, the nebulizer machine can be a little bulky, so you can't kind of take it places with you. And then you usually have to sit there for about 30 minutes to get the full dose of the medication. So it can be very time consuming. A lot of times we'll see infants maybe being prescribed nebulizer solutions because there's no way they're going to be able to use an inhaler, or maybe sometimes even older patients as well. The geriatric population might be prescribed nebulizers because they can't just quite coordinate the inhalers. So they might have to settle for a nebulizer instead. Any questions so far? All right, we will keep it going. So tablets, so these are the most common dosage form that we see medications in. So the compressed powders taken by mouth. The good thing here is that they're readily available. So most medications do come in tablet form. Long acting, long being a subjective term, usually about a day, could be just a few hours, but decently long acting. And the good thing with most tablets is they can be cut. So you'll see on some of them that they have lines that they could be cut. So you could adjust the dosage form if you need to, right? Rather than taking, if one of these pills is 10 milligrams, let's say you only need to take 5 milligrams, well, you could just cut it in half to get the 5 milligrams. So you could adjust the dosage form slightly as well. Or maybe it's too big to take, so you have to cut it in half to take it. Some disadvantages is they take a little bit before they start working. So sometimes they could take, an hour or two before they start working. Depending on the medication, it could take a few days before you see any noticeable changes. You must be able to swallow the tablet, of course, and then requires patient cooperation in terms of adherence. So sometimes a lot of the tablets, it could be you have to take it every so many hours, or you have to take it every day. And so adherence is kind of a big thing. So just remembering to take the medication can be kind of a big deal. So that is a disadvantage. Another one here is capsules. So the difference here is capsules are the powder or the liquid is in a gelatin shell. And it's taken by mouth. So the good things are they're readily available. So a lot of medications come in capsule form. Again, usually long acting, kind of like the tablets. And the good thing here is they may be opened or sprinkled. So if you can't swallow the whole tablet, let's say it's a younger patient that can't swallow the whole tablet, you could open it and sprinkle it on some sort of food, and they could take it that way. Not all capsules can be opened though. Some capsules, if you open it, that heavily increases the bioavailability, which again, we'll get to in a second about what bioavailability is. Disadvantages, again, could take a while before they start working. They cannot be cut. So you cannot adjust the dose here, just like you could with the tablets. So the tablets, you might be able to cut it in half or maybe a third, depending on how the tablet is scored. But capsules, you cannot. So you can't really open the capsule and just say, just take half of the capsule or half of the powder that's in it. So unfortunately, you can't adjust the dose there. Again, must be able to swallow, or you could open it depending on the capsule itself. And again, the patient has to just remember to keep taking it. We talked about solutions and suspensions. So they're powders that are suspended or dissolved in water or alcohol, and they're taken by mouth. So they're easier for patients who can't swallow tablets or capsules. Usually they act faster because you don't have to wait for it to disintegrate or to get liberated from the dosage form. So they usually start working a little bit faster than tablets and capsules do. The good thing with the solutions and suspensions is you could vary the dosing very easily, right? So with the tablets, you could only maybe cut it in half. With these, you could do, you just measure the liquid very differently. So rather than, giving 5 milliliters, you could give 6.5 milliliters or 7 or 7.25 milliliters. So you could adjust the dose very easily using solutions or suspensions. Some of the disadvantages are a lot of times they have an unpleasant flavor. The good thing is a lot of times they can be flavored. So at the pharmacy, we have different flavorings that we could flavor the medication with. And sometimes it's just a larger volume of medication. So sometimes people have to take 20, 30 milliliters at a time, depending on what the medication is. And that could be quite, a large amount of volume. Here's an interesting dosage form. So we have sublingual tablets, films, and lozenges. So sublingual meaning under the tongue, right? So under lingual is the tongue. So sublingual means under the tongue. The films would go on top of the tongue and dissolve that way. So if maybe you've seen like those Listerine films before, pretty much same thing. And then lozenges. So lozenges are usually kind of placed between the gum and the cheek and are dissolved that way into the saliva. The good thing with this dosage form though is it can be absorbed more quickly into the bloodstream because they're all getting absorbed through the saliva and then absorbed into the bloodstream from that way. So it's not going down your esophagus, into your stomach, into your intestines. So they're absorbed directly from the saliva into your bloodstream, so they can start working a little bit faster than other oral dosage forms. Disadvantages, we don't have a ton of medications that are available in this dosage form. All right, suppositories. They're small cone-shaped waxy medications. And again, they're placed in the rectum and they're absorbed that way. May be superior in treating constipation and very useful for nausea and vomiting, right? So if a patient is throwing up, you're not gonna wanna give them a tablet or a solution to help with the nausea and vomiting because they might just throw it right back up. And so that's a waste of a dose. So a suppository might be a better dosage form as well. And they are absorbed more quickly. And obviously disadvantage is patients find them uncomfortable. I don't blame them, but it could be uncomfortable to take. All right, so transdermal patches. So we talked about the difference between transdermal and topical. So again, they're medicated adhesive pads that are applied to the skin. They can be very long acting. So some could last a whole day or 3 days or a week. So they can be really long acting, which is pretty cool. Some disadvantages can be irritating, can be messy, and a lot of times patients complain that they don't stick on well. So maybe you have a patch on, you take a shower, and it keeps falling off. So they don't stay on as well as they should. Subcutaneous and intramuscular injections. So again, most of the vaccines that we give are given in either subcutaneous or intramuscular injection. Their medications dissolved in water or injected under the skin or into the muscle. So the advantages here are they have the widest duration of activity from several months to several years, and they bypass the gut metabolism. So we're seeing a lot of medications actually being converted into either subcutaneous or intramuscular injection to increase medication adherence, right? So 54% of people who take medications actually don't take them correctly. They forget doses, they miss doses, they feel they don't need to take it, what have you. One of the biggest populations of patients that don't take their medications correctly are those suffering from psychiatric disorders, so schizophrenia or maybe depression. They don't really take their medications for a number of reasons. A lot of times they feel that they don't need to take their medications, or again, they just forget to take it, what have you. So we're seeing a lot of antipsychotic medications being converted to long-acting injectables. So instead of a patient having to take tablets every day or multiple times per day, they come to the doctor's office or to the pharmacy. Pharmacists can now administer these medications as well. And they get a dose of their medication, and that dose will last them an entire month. So we don't have to worry about the patients taking their medications every day by mouth. So that's a real great thing about these injections. Obviously, a disadvantage is they require needles, and many people are afraid of needles, unfortunately. And it may require delivery by a healthcare professional. All right, and we also mentioned topicals, so ointments, cream, lotions, shampoos, gels, pastes, things like that. So their medications mixed into a proportion of water, alcohol, or oil. Ointments have more oil than creams, which have more oils than lotions. So ointments actually tend to stick on much better than creams or lotions. A lot of times if someone applies a cream or a lotion, maybe they put a shirt over it or it rubs up against something and it comes off. Whereas the ointment, since it's more oily, it tends to stay on the skin a lot better than the other two do. Advantages, so they're applied directly to the affected area and generally only affect that site. So again, they're local and not systemic, so less side effects, which is great. Disadvantages, not many medications can be absorbed across the skin, so there's a short, there are a lot that come this way, but not as many as we would like. And some are pretty stringent as well. All right, so those are the dosage forms. So any questions on the dosage forms that we went over before we get into pharmacodynamics and how the medications work? All right, so let's talk about compounding real quick before we talk about the pharmacodynamics. So compounding is the art of creating personalized medication for patients. I think this is where we're gonna see a big boom in the pharmacy world as well. So we have what is called pharmacogenomics now, which is pretty interesting. So pharmacogenomics, I like to compare it to like those ancestry tests where you send in a DNA sample and it kind of tells you your ancestry and where you came from and things like that. The difference here is when you send in the DNA sample, it kind of tells you how your body is made up in terms of different enzymes. So who can tell me what an enzyme does? Or what is an enzyme?
It like speeds up the reaction processes. It makes them go faster. Like without them, not everything's too slow to happen, to live.
Perfect, that's exactly right. Yep, so enzymes are proteins that are catalysts that speed up everything, right? So they speed up a lot of different processes that go on in our body, which include activating medications once they get into our body or deactivating the medications as well. So some enzymes, depending on the medication itself, Some medications need to be activated by those enzymes, and other medications actually need to be deactivated, right? Once they kind of have gone through the body and have done their thing, they need to be deactivated by those enzymes as well and taken out of our body, right? So pharmacogenomics basically tests your genetic makeup to see what enzymes you have or what you have a surplus of, what you have a deficiency in. And then that way we could kind of personalize medications for you. So we'll know before we even give you a medication whether or not it's going to work for you based off of your genetic makeup. And so we know, or we already know, that some ethnicities lack certain enzymes. So the Asian population actually lack an enzyme called CYP2C19, all right? So there's this medication called clopidogrel or Plavix that actually uses CYP2C19 to become activated once it's in the body, all right? So it's what we call a prodrug that needs to be activated once it's in the body. So what do you think might happen if we give an Asian person Plavix or clopidogrel? What do you think might happen? If they are deficient in 2C19, what would then happen? Oh, by the way, Plavix or clopidogrel is a blood thinner, so it helps to kind of thin the blood and prevent a stroke or a heart attack. So what do you think would happen if we gave an Asian person Plavix or clopidogrel? Any thoughts, ideas? Nothing? So if 2C19 is supposed to activate the drug, and that population is deficient in 2C19, there's a good chance that the drug isn't going to be activated, right? Which means that they'll still end up getting blood clots, could possibly get a stroke or a heart attack. So the medication is not going to work for them, right? And so that's the cool thing about pharmacogenomics is we'll know in advance what medications will work and what medications won't work for patients. And so rather than just on the ethnicity level, we're now going down to a personal level for pharmacogenomics. So people can now actually send in their DNA samples and learn what their genetic makeup is. And so then they could get personalized medications, right? So maybe there's a certain medication that only comes in 10 milligram tablets and 20 milligram tablets. Well, this patient needs 17.5 milligrams for it to work exactly how it should work and hopefully avoid any side effects. And so that's what compounding does. So that's what compounding pharmacists do. So they make medications personalized for patients, whether that be certain doses or strengths of a medication, certain dosage forms of the medication, flavoring or sweetening, maybe removing allergens. So I have a patient at the pharmacy that I work at who's allergic to every color dye under the sun. So she could only have white tablets. And so compounding pharmacists could actually remove any colorings or any other allergens that a patient might have an allergy to. And then they could also help avoid undesirable side effects by personalizing medications for a patient's own genetic makeup. And so, one area that this is common in is, when women go through menopause at a later age, their hormones are kind of all over the place. And so, each individual person needs their own individualized dose of hormones. And so that's where compounding pharmacy comes in. So they kind of individualize medications based off a person's genetic makeup. The only thing with compounding is it can only be used to compound products that are not already commercially available. All right. So for example, if a patient, let's say they're picking up a prescription that, costs them $100 and they can afford it, technically they cannot go to a compounding pharmacy to have that compounding pharmacist make the same medication in that dosage form because, it's already being commercially available. All right. So they could tweak the dosage form or the dose slightly, and that would be okay, but they can't make the same exact thing and charge them less, unfortunately. So any questions on compounding or pharmacogenomics? All right, so let's move on and talk about
Looks like there's a
pharmacodynamics.
question in the
Yes.
chat, actually.
Is there one? I can't see the chat.
Sammy Jensen asked, how frequently do pharmacists make personalized medications?
Great question. So there are dedicated, compounding pharmacists. So very frequently. So not every pharmacist can do this. So if you go to your local CVS or Walgreens, they're not gonna be able to do this. So you have to go to designated compounding pharmacies to do this. They're usually like locally owned, like mom and pop pharmacies. So it actually is a very common thing. There's a couple near where I live. And a lot of what they focus on is those hormone replacement therapies. They also personalize dosage forms for younger children as well, so they can make dosage forms in terms of gummy bears or lollipops or popsicles or any other dosage form that would increase a patient's adherence to the medication. So it is a very common practice, but again, you're not going to find it at your local CVS or Walgreens or anything like that. Good question. Thank you for asking. Any other questions? All right. So I keep mentioning bioavailability. What is that? So it's a percent of a drug dose that reaches the blood before it is metabolized. So metabolized meaning before it starts being broken down by the enzymes, right? So it's a percent of the drug that reaches the blood before it's metabolized. So when we talk IV or intravenous administration, that is 100% bioavailable, right? So the entire dose of the drug goes into the bloodstream. Whereas if you take medications by mouth, they're not 100% bioavailable, right? Sometimes the whole medication doesn't get liberated from the dosage form. Sometimes there's incomplete absorption. Sometimes there's pre-systemic or what we call first pass metabolism. So it's already being broken down by the liver before it gets to the bloodstream. Or sometimes maybe the stomach starts to break it down. The acid in the stomach starts to break it down before it gets to the bloodstream. So there's a lot of reasons why not the full dose of the medication gets to the bloodstream. So if you have, let's say we have one medication that comes in an IV administration and an oral dosage form as well. Let's say the IV administration that works for the patient is 10 milligrams of that drug, right? So we're going to give drug A 10 milligrams by IV route to this patient, all right? And the patient's in the hospital. All right, so the patient's going to be going home now. And so we want to give the oral formulation to the patient, all right? So would we give a higher dose of 10 milligrams? Would we give a lower dose of 10 milligrams? Or would we give the same 10 milligram dose to get the same effect? What do you think?
You would have to give higher.
Excellent. Yes, you'd have to give a higher dose, right? Because part of it is going to be broken down before it even gets to the bloodstream. So thank you. Yes. So a higher dose than the 10 milligrams. Good.
I was also wondering, like, is there like downsides or negatives to you having to take this medicine so it's broken down by your body? It's just broken down and then like ineffective as medication, but is it like bad that you had to break that down? Like, is it hard on your body to have to break that down?
It could be, yes. So when we talked about like acetaminophen or Tylenol, for example, it can be hard. So the enzymes that really break down those medications are mostly found in the liver. And we'll talk about that in a little bit here, but they're mostly found in the liver. So medications that really require a lot of breakdown by the liver could be really hard on the liver. So it can be, it definitely can be a little harmful to different parts of your body. So, as pharmacists, a lot of people think that we're trying to push more medications onto people, and we're not. We're trying to actually, a lot of times, take people off of medications if they don't need to be on them, because we know that they could cause harm to different organ systems. And so, when we talk about like monitoring parameters, a lot of times when people are on certain medications, we have to monitor their liver function, make sure their liver is still functioning properly. We have to monitor their kidney function to make sure their kidneys are still functioning properly. And we'll talk about why we're talking about kidneys and liver in just a second. But yeah, so, a lot of times there are monitoring parameters that we have to go with or monitor when patients are on certain medications to make sure that it's still safe and that it's not harming the body too much. Good question. Any other questions? All right, so let's talk about pharmacodynamics real quick. So when a drug is taken by oral route, here's kind of what happens. So it has to be, so let's say it's a tablet. It has to be liberated from that tablet, right? From that dosage form. So it has to be liberated from that tablet. And that usually actually happens in the stomach, right? So the acid in the stomach kind of breaks everything down, breaks that tablet down, and it liberates the drug itself from the dosage form, right? So the tablet doesn't just have the drug in it. The tablet, so a lot of drugs are measured in terms of milligrams or even micrograms. So that's like a really small, tiny amount. And so it's not the whole entire tablet isn't drug, right? There's a lot of fillers in there to make it a decent size so that, we could actually handle the drug properly. And so a lot of times tablets will have like lactose in them and maybe some other fillers as well. But so the drug itself needs to be liberated from that dosage form. And that, again, usually happens in the stomach. It then needs to be absorbed, and that usually happens in the small intestine. And we'll get into each one of these in a little more detail in a second. Distribution, so that goes into the bloodstream and it goes to the tissues and target sites that we want it to go to. Metabolism, again, so you have to inactivate or deactivate the drug itself, and then you need to get it out of your body, right? So once it's inactivated, we need to get it out. We don't want it, roaming around in your body, so we need to excrete it as well. So again, I'll talk about it in a second. So liberation, again, disintegration, mostly in the stomach. And then absorption. So most absorption actually happens in the small intestine. Did you know that the surface area of the small intestine is actually the size of a tennis court? Isn't that crazy? You have the size of a tennis court in your small intestine. That is a surface area because there's so many little microvilli, so they're going up and down, up and down, up and down, that increases the surface area so much. So most medications are actually absorbed through those microvilli in the small intestine and into the bloodstream that way. All right, so most absorption of medications actually happen in the small intestine. Once they're absorbed into the bloodstream, they need to go to their targets, to the cells that we want them to go to. And so depending on the drug itself, depending on the size of the drug, depending on the lipophilicity of the drug, depending on the polarization of the drug, tells us how easily or not easily it is for the drug to get into the cells and do its job, to do what we want it to do, right? So the size is measured in Daltons. So the smaller the drug, the easier it passes through the cells, right? So this is the blood right here, the extracellular fluid, the intracellular fluid. All right, so the smaller the drug is, the easier it passes through. So drugs of size less than 50 Daltons will be much easier to pass through and go into the cell. Drugs that are lipophilic, so fat-loving, actually pass through the cell membrane much easier. Why is that? Remember from your biology classes that the cell membrane is mostly made up of lipid, right? A lipid layer. So drugs that are lipophilic tend to pass through the cell membrane much easier and get into the cell.
I guess I do have a question to go off of that. Is there like a good major you?
Sorry, okay, I wasn't sure if that was for me or not.
Sorry, my mic was unmuted. That was
It's okay.
Panel.
It's all right. It's not a problem at all. Not a problem at all. And then the polarization, right? So if a drug is more polarized, it's going to need a little more help getting through the cells as well. All right. So it just kind of depends on the drug makeup. All right. When we talk about metabolism, I want to try to get through this so we can get to the Kahoot game real quick. When we talk about metabolism, that usually, again, that happens in the liver. So most of the enzymes that break down the drug are in the liver. So we see all these different, what we call CYP enzymes. So 36% are 3A4, 16% are 2C89, 2D6, and that's how we get drug interactions, right? So a lot of times medications, again, need to be deactivated by these enzymes. So they went around, they did their thing, and now they need to be deactivated. Or if they're a prodrug, like we talked about with clopidogrel or Plavix, they need to be activated by these enzymes. Here's the thing. Some drugs are what we call enzyme inhibitors, all right? And some are what we call enzyme enhancers. So some drugs will just kind of, once you take it, it might completely stop that enzyme from working, right? So they'll take up space on that, the receptor site, and they'll just kind of stop that enzyme from working. So that's an inhibitor. And some are enhancers, and so they'll actually ramp up the activity of those enzymes. And so that's how we have drug interactions. So if we have drug A that needs to be metabolized by, let's say, CYP2C or 2D6. So drug A needs to be metabolized or broken down by CYP2D6. However, a patient is also taking drug B, which is a 2D6 inhibitor, right, which is going to stop 2D6 from working. Well, what is that going to mean for drug A? Are we going to have more of drug A roaming around our system or less of drug A roaming around our system? If it needs to be metabolized by 2D6 and drug B inhibits 2D6 from working, what does that mean to the levels of drug A?
It's not going to be able to be metabolized.
It's not going to be able to be metabolized, right? So it's not going to be able to be broken down. So what happens to the levels of it in our body?
I think there would be too much.
There would be too much. Exactly. There would be too much. So then how do we bypass that? If a patient needs to be on both drug A and drug B, we would then lower the dose of drug A, right? So sorry, Brooklyn, if you want to answer that and I ruined your party. I am so sorry about that. I saw you unmuted there.
No, you're fine. You're fine. I just want you to have some interaction. I like this.
Thank you. Thank you. I appreciate it. So as a pharmacist, I would call the physician and I would say, I recommend lowering the dose of drug A because they are on this enzyme inhibitor that's going to increase the levels of drug A. So let's lower the dose of drug A if they need to be on both drug A and drug B. All right. So any questions on that? All right, excellent. So let's talk excretion. All right, drug's broken down. We need to get it out of our body. How do we do that? The kidneys, right? So that's what's up here. So the kidneys are the biggest source of excretion for our body. So most drugs are excreted through the kidneys and into the urine, all right? Sometimes they are excreted by the liver through our feces as well. So sometimes it goes in the feces too. And some drugs are also excreted through your tears, through your sweat, through your breath, or through your saliva. Well, this one's through your saliva, sorry, through your saliva. This one is through your breath, and then this one is through breast milk as well. So for lactating mothers, it could go through the breast milk. So a lot of times we want to know if a patient is lactating or not, and make sure that they're not on any medications that can go through the breast milk and into the fetus or into the child, because that would not be okay, right? All right, so that is excretion. Any questions on that? All right, let's go to Kahoot. Hopefully you're all familiar with Kahoot. And let's play a game, all right? We have 15 minutes or so. All right, let me share my screen with you and we'll see who is paying the most attention and who knows what they're talking about. All right, so there's the pin, 2130239. We have one more joining us, or should we go with these four? Maybe like 10 more seconds and then we'll get started. Excellent. All right, let's go. All right, where's the primary site of absorption for sublingual tablets? All right, so we have 3 respond. Under the tongue, excellent. Yes, remember sublingual, so under the tongue. Excellent. All right, Alex is in the lead. Which of the following dosage forms would be best for long-acting, greater than 1 week medications? All right, yes, so intramuscular injection. Remember how we talked about some of those antipsychotic medications? are intramuscular injections, and they can last upwards of a month or so. So a patient only has to come back every month to get a shot, and so then they don't have to worry about taking tablets every day. Good. All right. Which of the following dosage forms would be best for a patient experiencing nausea and vomiting? Good, most people want a suppository. Excellent. Yes, remember, so we would prefer not to give a patient a tablet or oral solution or oral syrup because they might just throw it right back up. So you'd want to go with another dosage form that doesn't have to go through the stomach. So excellent. Brooklyn took the lead. Which dosage form would work the fastest to relieve shortness of breath in a patient with asthma? Good, inhaler, yep, exactly. So that's gonna go right down into the lungs. Excellent. All right, which dosage form has 100% bioavailability and works the fastest? Excellent. Intravenous, exactly. So remember, IV intravenous, it goes right into the veins, right into the bloodstream. So 100% bioavailable, and it does work the fastest because it goes right into the bloodstream. So a lot of times, obviously, when patients are in the hospital, they're admitted to the hospital, they set up an IV line just in case something happens, a patient codes, and you could get right into the bloodstream right away. So most patients do have an IV line set up when they're in the hospital. All right, the small intestine primarily affects which part of the LADME process? So remember, LADME stands for liberation, absorption, distribution, metabolism, excretion. And you guys didn't need me for that. Excellent. Absorption, good. Yes, remember the largest surface area, and so it affects absorption. The liver affects primarily which part of the LADME process? Good, metabolism, exactly, yep. So the most of the enzymes that break down the drug are in the liver, and so it affects metabolism, good. The kidneys primarily affect which part of the LADME process? Good, excretion. So most of you, or all of you, are with excretion. That is excellent. I feel like I had another follow-up question. Maybe I didn't. Okay, we'll move on past that. So, well, let's say a patient has chronic kidney disease, right? So their kidneys are not working well. What would we want to do with the doses for their medications, right? Let's say they get into acute kidney injury or chronic kidney disease. What would we do with their medications? Would we keep them at the same dose? Would we increase their dose? Would we decrease their dose? So if their kidneys aren't working well and they're not excreting the drugs, what would we do?
Wouldn't you want to decrease the dose since it can't filter out any of the extra that the body is not using?
Exactly, exactly. Yep, so we would decrease. So, and a lot of times medications are dosed differently based off of kidney functions, right? So when we talked earlier about monitoring the kidney function, monitoring the liver functions, this is exactly why, because that tells us if we need to adjust the doses of any of the medications, or maybe even completely take the patient off of any of the medications as well. And so kidney function, liver function are often monitoring parameters for a lot of different medications. Good. Right. A patient says the cream he was prescribed is not staying on his rash. Which dosage form would you recommend instead? Ointment, excellent. Yes, remember ointments more oily, they tend to stick on the skin a lot better. Good. You wouldn't go with a tablet or anything that is absorbed systemically, because again, we would rather just have medications work at the site that we want them to work at and not get that systemic absorption and cause those side effects, right? So if there's any possibility of using a medication that is just going to work locally, we would rather do that than use systemic medications. All right, which of the following patients would not be a candidate to recommend to a compounding pharmacy? This is going to be the last question. I know it says 15, but this is going to be the last question. All All right, a patient is trying to lower the cost of their medicine. Exactly. Yep. So remember, we can't do that, unfortunately. And it looks like Brooklyn is the winner. Congratulations, Brooklyn. Excellent. We do have 7 minutes left. Do you guys want to play is this candy or is it a drug game or not? Because I have 5 questions. That's what these last 5 questions are. Is this candy or is this medication?
Let's do it.
All right, let's do it. All right. Which one is the medicine? And it might be a little hard to see, but they look very similar. Good, so most of you on the picture too. Exactly, that is the medication. So those are multivitamin gummies. Which one here is the medication? Excellent. That one was a little easier. So that one looked like the medication. So picture 2 was the drug there. Which one here is the medicine? Ooh. Oh, excellent. Good. So the first one, picture 1 was a jelly bean. The one here is actually an iron supplement. The other one was an iron supplement. All right, this one's a little trickier, maybe. They both look like chocolate to me. Excellent, yes. So I don't know how you guys are doing it. Maybe it's just me. I don't know. You guys are better at identifying it than I am. So the one here is the X-Lax, and then the other one was just regular chocolate. All right, last one. Excellent. Wow, you guys are awesome at this. Yep. So that was an aspirin tablet. The other one was an Altoid mint. All right. And so the overall winner, I think we know. Congratulations, Abby, for 3rd place. Congratulations, Alex, for 2nd place. And number 1, Brooklyn. Excellent. I wish I had a prize to give you. I'm sorry, I don't though. But congratulations on that. So what questions can I answer for you about dosage forms, about the profession of pharmacy in general, about Neomed, anything?
I actually was kind of interested on like your thoughts of supplements and like daily vitamins, stuff that like is not prescribed, you don't need it, but just extras. I know it can like especially relate to diet and stuff and what you're getting through your diet, but just and if you personally take any, if you mind sharing that or just your thoughts.
Yeah, that's a really great question. Thanks for asking. So yeah, so multivitamin. So if you're talking like a multivitamin tablet, I usually recommend those for patients who, a couple of different types of patients who have terrible diets, right? Who aren't eating fruits and vegetables, who aren't getting those vitamins from their diet. And it could also be, so a lot of times patients actually get like gastric bypass surgery or other sorts of surgeries like that take out part of their small intestine. And so some vitamins and supplements aren't being absorbed properly that way by their food. So then we have to come up with other dosage forms. So for example, patients who do have some sort of bypass and are bypassing the first part of the small intestine, because it's really the first part of the small intestine is where most of the drug absorption happens. And so if you're bypassing that part, then a lot of times the vitamins aren't being absorbed as they should, so they're deficient in those vitamins. And so we have to come up with like another dosage form. So usually we go with like a sublingual dosage forms, because remember, they're just kind of absorbed through the saliva and into the bloodstream that way. So they make sublingual dosage forms of multivitamins for patients who had to bypass surgery that way. So multivitamins, again, usually for patients who have a terrible diet, I'll recommend that. The other vitamins, like the standalone vitamins. So for example, I take vitamin D supplement every day. I know that my vitamin D levels are low. I live in Northeast Ohio. We don't get a ton of sun around here, especially in the winter. So I like to take vitamin D supplements, again, mostly because I know that my vitamin D levels are low. So a lot of times those, standalone vitamins and supplements only if you kind of have a deficiency in there, and that is usually where I'd recommend them. Because the combined multivitamins that have all of the vitamins and stuff in them, they just have a really tiny amount in there, so that's not going to do much for you. But if you have an actual deficiency in, for example, vitamin D or vitamin B12 or anything else, then yes, definitely you could take those standalone vitamins. I wouldn't recommend a multivitamin just because it's not going to have enough of what you need. But the multivitamins, again, usually for, I know my diet isn't the best either. I probably could take a multivitamin, but I don't. And that's why a lot of times you see children get prescribed multivitamins because they're eating chicken nuggets and fries all day. So that's why they not get prescribed, but they take over-the-counter multivitamins because their diet isn't so great either. Any other questions that I can answer? How did I know pharmacy was the right career for me? So I became a pharmacy technician. I had no idea what pharmacists did until I became a pharmacy technician. At the age of 18, and you need a high school diploma, you can become a tech. So that's what I did. I became a pharmacy tech, and I absolutely loved what I saw. I saw my pharmacists have a huge impact on their patients, and I absolutely loved it. And so that's how I knew I wanted to be a pharmacist, because we're one of the most trusted healthcare professionals that there are. And so I knew that that's what I wanted to do. Other questions that I can answer for you?
I'm interested in going to medical school, so not pharmacy school, but do you have, I know in the retail setting, you don't have quite as much interaction with doctors as you would like in a hospital or anything, but from your perspective, is there anything that you wish doctors or physicians that were sending in prescriptions understood or knew more about the pharmacy profession, just looking towards the future?
Yeah, so we have, what we call an ideal world, and we have the real world. So the ideal world would be we could prescribe whatever medications that we know is going to help our patient the most. And then you have the real world where you have to deal with insurance companies that say, no, we're not paying for this, right? So then what do you do? And so just kind of, making sure to work together as a team, trust your pharmacist. We know what we're talking about. We get a 4 years of school just learning about medications. And so we are the medication experts. I mean, most physicians get a semester or 2 of pharmacology, same with nurses, same with the other healthcare professionals. They have to know a lot about other things, right? I can't diagnose as a pharmacist. I can't recommend alternative treatments as a pharmacist. I know the medications. So, let me kind of help you manage the medications, because I know what I'm talking about when it comes to that. So trust your pharmacist and, work with them because, again, insurance companies kind of rule the world, unfortunately. And so we have an ideal world and we have the real world. And so we got to work together and put our patients at the forefront. All right, excellent. Thank you all. I have to jump on another Zoom real quick, but thank you all for joining. Hopefully I'll see you maybe in another session later today. Have a good day.